behalf of my co-moderators, Dr. Skaya, Dr. Jack Ziegler, and Randy Davis, who's live in a blue sweaty. It's very cool to have all of you together to see what our East Coast Alliance has put together. Manny, do you want to take it on?
Yeah, sure. Thanks, Jens. Thanks, Dr. Geyer, Dr. Ziegler, Dr. Randy Davis. I don't know, the last time I saw you, I think it was in Baltimore. And thanks for having us do another session. I'll be presenting with Dr. Puvanesarajah over in Rochester, even though Dr. Chapman called it Buffalo, but we'll go back and call it Rochester. And I've known Varun. I've known Varun since
Apologies.
I've known Varun since I was in medical school, and I was a junior faculty in Texas, and he did residency at Hopkins, so we shared that in common. And also was recently my partner along with Dr. Molinari in Rochester. So we're happy to continue the partnership and share cases. We have four cases to go over today, interesting spine, cervical spine cases. And this just happened again. Let me try sharing this again. We have four cases to go over. We're going to alternate back and forth. And the goal is we'll try to get through some of the maybe more common cases taken into account that we have residents and fellows presenting. So maybe we'll get to the more complex stuff later. But we would like to present cases that are more likely to be seen by most of the audience, and then hopefully get into the rest of the cases if we have time. So going directly into it, the first patient I'll present here is a 57-year-old female who presented to my clinic, recently immigrated to Rochester. So this is a patient I took care of in Rochester about 4 years ago now. Came from Puerto Rico, presented to clinic with neck pain and gait instability. She reported progressive gait instability, clumsiness in her hands, dropping of objects, difficulty with using her fingers, progressive urinary incontinence over the past several weeks. So the classic signs and symptoms of myelopathy, with the physical exam finding normal strength above in the top, upper and lower extremity, positive Hoffman, positive inverted radial reflexes, difficulty with heel and toe walking, unsteady gait. Had to have to hold onto the wall like grabbing something when she was walking. So one of those classic patients that you're sending directly to the hospital for direct admission. But as you see with our past medical history, she has type 2 diabetes with hemoglobin A1C of 9.9, and those are the only values we had, hypertension, depression. And even though she reported 2 years of progressive symptoms, she said over the past few weeks, her symptoms have gotten pretty bad and she's really unable to do anything. I'll go to so here are x-rays. The x-rays are pretty benign, just some slight loss in reversal of her cervical lordosis, but overall doesn't look too bad. And this is the MRI she presented with, and I'll scroll through the MRI. So that's looking at C23. She has this protrusion at C23, indent in the thecal sac or the spinal cord, but not too bad, and severely right there. 3-4 is the severe stenosis. At 4-5, quite severe. And that was the worst level. Get on to 5-6, the same severe cord compression. 6-7, severe cord compression with some foraminal stenosis. Not too much ridiculous symptoms, just mostly myelopathic symptoms and consistent with the physical exam presentation. So this, I guess by now, I think most of us are thinking possible get a CT scan to evaluate for possible OPLL versus just acute disc or multiple disc herniations. But I think we can all assume OPLL more likely. I guess for the panel, I guess topics is with you have an MRI like this, do you typically go for a CT scan or do you do a CT with myelogram? I know depending on where you are, as Dr. Chapman mentioned, one thing I noticed when I moved to Rochester after I did med school there, but when I moved there in practice 8-9 years ago, one thing I noticed was a lot of high use of a CT myelogram. Do you incorporate this when you see some of these patients who already present with an MRI? Do you still get a CT myelogram or do you just depend on the CT scan?
Manny, I would say always CT and rarely CT myelography. I once worked with a really good neuroradiologist at Rancho who used to call this a punitive myelogram. He said there's nothing you couldn't get with a plain CT and an MRI, where obviously you can see intrinsically in the cord that you couldn't even see on the myelogram unless there was a syrinx. So for me, it would be always CT and not a CT myelo as long as you had a good MRI.
And I would agree with that too, Manny,
Yeah.
because you have your soft tissue windows, you have your bony windows, you
Mhm.
have an MRI scan that shows the cord is really, really compressed. So it's just a matter, is it hard or is it soft?
Yeah. Yeah, no, and that's typically my go-to is the MRI, and if I have to do additional study, the CT. And I know sometimes you see some of these patients with older pacemakers that are not MRI compatible, or we're not sure if they're MRI compatible, or is the patient actually dependent on the pacemaker? Do they actually can it be turned off? So I always go, and I think that's something that we take to my. I always go the extra mile to see if I need to contact their PCP, because I think sometimes if you live this up to the radiology tech who's doing the study, most of the time they say no to the patients that they can get an MRI. But I always push to talk to whether it's a cardiologist, want to see if it's MRI compatible, so you don't have to turn it off, or if the patient is dependent on it, and is it something that we can get cardiology involved so they can be on standby while the MRI is done. And if worst case scenario, if we cannot get an MRI, that's when I get a CT myelogram. But I always try. I think the MRI is still for me is still the best study to evaluate the neural elements, and especially if you're looking at in some cases where you're looking for foraminal stenosis. So we got a CT scan, and you can see the lesion there beginning at. I'll scroll down, beginning at C23. This looking through the sagittal, and you see the OPLL lesions. Then this is going through the axial, and this is the area of most severe stenosis at the C4-5 level. And this is just showing, this is just a schematic view of the different types of OPLL. And so this patient has more of a type B with a double layer type with a dural ossification, and OPLL at the same level, which is separate from the epidural space. And going back again to show the key image with most severe OPLL at the C4-5 level. So again, back to the demographic and brief synopsis of the patient. So this is a patient presenting with myelopathy, and obviously the patient is not healthy with poorly controlled diabetes with a hemoglobin of 9.9. But I think it's one of those unique situations where you have someone with severely progressive myelopathy. They're not necessarily the healthiest, that the person you signed off for elective surgery, but I think this patient is more on the urgent side of things where you have to figure out how do you bypass this. So would anyone wait to control the diabetes before proceeding to surgery? And what options do we have for intervention?
Jens, you should take this. This is the softball for
Yeah,
you.
no, I mean, for me, this is a very clear, strong surgical indication. And of course, the A1C level is a significant warning sign. I would put that as a risk mediator. But I forgot what Nurek scale she is and what her MGOA score is. But unless it's like 13 or 14 on the MGOA and she's a Nurek 1, I would consider doing the surgery earlier. And for me, this is not a question. It's a C2 to T1 or T2 posterior decompression fusion. Yes, with steroids, yes, with IMAPs, and I would not in the world go anteriorly. A laminoplasty is not, although it was designed for this originally, is not a good surgery for OPLL because we've now seen that the OPLL continues the genetic modification, and maybe you're going to talk about that, Emmanuel, is created by a stimulus from traction or tension signaling on the Sharpie's fibers that creates this hyper ossification. So, and I would absolutely not go anteriorly to the very high risk of dural tear and extraneural decline. So posterior decompression, wide laminectomy, long instrumentation with decompression above and below the anticipated anterior problems, and then reevaluate the patient from there. Thanks.
Yeah, what are your thoughts on as far as like risk with the posterior surgery? I know you mentioned laminoplasty, and as you mentioned, yeah, I think because even with those evidence also supporting when you fuse, even some of those areas that you do not decompress anteriorly, they lose some of that calcification with fusion. What are your
Yeah,
thoughts now with the posterior decompression, especially at the C4-5 level with the dreaded C5 palsy?
yeah. So again, this is a great question, and in these patients, for me, there are two types of human beings. Not going to political hot water here. They're bone formers and they're bone non-formers. These are bone formers. So you can do extremely wide decompressions. You can do wide femonotomies, especially at C4-5 is a great point because what you want to have is that the cord falls back. And we now know and strongly suspect, however, that the C5 palsies come from traction. So releasing that is a very important thing, and being on the watch out and informing the patient beforehand. And that's that. But I would not veer from my strong suggestion to do it posteriorly only. If you somehow later on felt that you had to go anteriorly again after you've done a posterior decompression, it's a completely less risky undertaking. And again, I've had a very large number of OPLL patients I've not published on, but I track them faithfully. The only thing I would add to my workup is I'd get a CT of a thoracic and lumbar spine because they can have disease at other levels also. But that would not change my approach towards the C-spine first.
Jens, I was a little surprised that you put laminoplasty down the list so far, despite some literature suggesting that decompression fusion is better. You could still do a laminoplasty and get her off the table a lot quicker. And just that would still be my go-to operation, I think, for this rather than a longer fusion.
I've just seen them grow myself. And again, now that we know what OPL is caused by, it's that traction phenomenon that's genetically inclined, trying to minimize the traction spur. And yes, Emmanuel's totally right. It can grow even with a posterior fusion. It's that strong of an impulse, but that's my best bet at not letting it happen. Even Japan, they're going away from laminoplasties for OPL, for true OPL. And this is severe OPLL. This is a very difficult surgery to do. There's many risks, not just soft tissue wise and infection wise, but also cord or root deterioration. So, but posterior, I remain firmly posterior fusion. I'm curious what others say.
Although the Japanese still occasionally report, even at CSRS, and going anteriorly and spending time. And of the few times in my career that I've regretted being in the middle of an operation, it's been going after one of these anteriorly and just saying, why did I do this? So, they're a little bit more aggressive than we are in some of these cases. You always worry about the anterior spinal artery also when you're dealing with something this compressive and this hard.
Yeah. Would anyone go anteriorly?
Well, Manny, I was going to ask you, what would, suppose you do the posterior decompression fusion that Jens talked about, she gets a little improvement. What would make you want to go anteriorly?
I think I'll get an MRI, see how the soft tissue envelope falls down. And if she did not, with myelopathy, we talk about preventing progression of disease. And I think I think it's a tough question and tough thing to decide because is the patient not improving because we just couldn't get any more improvement from the surgery, or is it because of some persistent stenosis? And I think that's a tough thing to answer. I'm not sure if I have the perfect answer to that to whether or not when do I go back and do anterior surgery?
And Manny, if you would, the Japanese describe just, doing the corpectomy and letting the fragment adhere to the anterior cord or dura and just let it float back. Is that the technique that you'd use?
Yes. So with anterior, I've had a few patients I've gone anteriorly understanding the risk. I think I was stressed for those who did not get it, as Dr. Chapman mentioned. The biggest risk going anteriorly is dura tear, and knock on wood, I haven't had a dura tear from anterior cervical surgery, but knowing that it's not an easy thing to take care of if it happens. So for the few patients that have taken the risk of going anteriorly, is certainly a concern, and you take your time. It's not the typical ACD if you go in and you move fast and get things done and get out of there. I think you take your time. I've had a couple of patients where I really went in and looking at the CT scan and MRI, I felt I had a window to go between the OPLL and the dura. And like I said, I've been lucky to be able to do some of those without having to do posterior surgery, or to at least go anteriorly to thin down that fragment to a floating mass before going posteriorly to finish up the surgery.
So what did you do in this case, Manny?
So in this case, Dr. Chapman, don't go anteriorly. I went anteriorly first.
I think he left. It's okay.
Yeah.
I'm proud of you. I'm proud of
take
you.
it. So, oh, he's back. So I went anteriorly at that level. I did partial corpectomy at the C4-5 level, and then because of the severe foraminal stenosis, just addressed that and was able to take down some of the OPL at the lower levels. I didn't go to the C3-4 level for her. So just address, I figure since I was there anteriorly, just take care of that. I think I did the first part on Monday and the second part on Tuesday. So did the anteriorly, went anteriorly, thinned everything down. And I'll show you I got a post-op CT scan and went posteriorly and did a decompression and relied, as Dr. Chapman mentioned, at a 3-4 level. I undercut the C2 lamina and did not take it off completely. And I'm dependent on my fusion to stop the progression and maybe some resorption of the OPLL at the C2-3 level. So I was able to thin that down to this little fragment right here, as you see on the sagittal and the axial, and created a floating mass. And this is using a high-speed burr, using the AM8 burr, but it took my time and thinned it down as close as I could, and not get too aggressive and too greedy with getting that fragment off. And then went posteriorly and did a wide laminectomy, as Dr. Chapman mentioned. I think she had a little bit of a weakness post-op, but she recovered very, very well. And so that was
a question.
Yeah.
What did you gain by going anteriorly that you couldn't have done by just going posteriorly?
I think my concern was that it was so thin posteriorly that even if I decompress posteriorly, the cord is still draped over that fragment. And then it's that paranoia about the C5 palsy at C4-5, which we know from majority of the patient that improves. But I felt, given just looking at analyzing the images more critically, I felt maybe if I can get rid of that large fragment, that I don't have to worry too much about whether or not the cord is appropriately draped over that huge mass.
But the piece of bone, although albeit thinned out, is still there. So you're hoping just by floating it that maybe the cord would be a bit more mobile?
Correct.
Great.
Yeah. So those are the final images. She ended up as expected with wound dehiscence, luckily not infection. So we got her admitted directly from clinic to the hospital, got endocrine to see her right away in the hospital, and they provided a regimen to help manage her diabetes. She did well, went home, came back 3 weeks later with some wound dehiscence. I think it's one of those cases too, maybe from the index surgery, maybe I should have gotten plastics involved. So with the dehiscence, I got plastics involved, especially not your typical dehiscence. This is dehiscence from someone with a hemoglobin A1C of 9.9. So plastics got involved and they did a beautiful job closing it. And she healed perfectly. All right.
You're a gutsy man. Kudos to you. Great surgeon as always.
Beautiful job and a good outcome.
Thank you.
How was the swallowing afterwards? Is that a problem for her?
No, she didn't have any issues with swallowing. I think I try to avoid or minimize the risk of that too by not trying to go after the fragment at C3, 4, 2, which we know the higher you go can increase the risk.
So it's beautifully done, and congratulations to you. I mean, you always impress me with great surgical skills. Just on a general perspective, our surgical lives changed to an OPLL surgery done anteriorly. In Boston, from a good friend of ours, an anterior decompression was done on an OPLL patient with CSF leak and quadriplegia, whilst the surgeon was in another room also for scoliosis surgery. And that case served as a sentinel case for all of us to not be done. Again, this was an OPLL case. In retrospect, it should have probably never been done anteriorly. But that was a secondary point to the fact that in the eyes of the attorneys, this was done because of overlap, or the problem happened due to overlap in surgery. So I've always seen that as a sentinel sign of don't go anteriorly unless you absolutely have to. And even then, if you went posteriorly first, the cord falls away and you have far greater leeway. The cord becomes far more elastic, but nicely done. Congrats. That's off.
Thanks.
Hey, to thin out that OPLL anteriorly, did you use a high-speed burr or did you use a Masonics?
I used a high-speed burr at that time. I'm not sure if we had. I've used the bone scalpel, but I've never actually used the bone scalpel burr. Which, in retrospect, I think if I had access to that, I'm not sure if we had it. I don't think we had it at the. We actually no, we had it at the hospital, but I'd never used that burr before. I've always just used the scalpel itself, but I've never used the burr. But I think you're absolutely right. I think this may be safer using that burr than using the AM8 burr.
Yeah, the only problem with that, Manny, is watching the irrigation come out. You keep wondering, is it CSF? Is it CSF?
That's true.
And that's the only thing I don't like about it.
Yeah. All right. Let Varun pick it up with another very interesting case.
Yeah, sure. Thanks, everyone. Thanks for having me back. Yeah, Menga, I thought that was a really good case. That's a really good outcome on that one. All right, let's take a look here. Can you guys see my slides okay?
Yeah.
All right. So patient one. So this is a 50-year-old male with a history of metastatic renal cell carcinoma. He had a previous right radical nephrectomy 2 years prior, and he had no metastatic disease at that time. Recently, he did start developing a metastatic disease burden, and he was stats post left hemiarthroplasty and distal femur curettage. And then after that, he actually ended up being treated with immunotherapy and had a great response. In that whole process, he did have some cervical spine radiation. Key here is that after he had that immunotherapy, he started developing really significantly worsening neck pain and a head tilt, but he never really developed any neurologic deficits. This is a clinical photo of him here, and I think the keys here that you can see that head tilt, you can see that how he's kind of extended. You can see how his shoulders are actually the alignment of his shoulders have changed because he's actually sort of changing his alignment to sort of keep his head straight. I think those are all sort of important cues that kind of give us a better idea of what's going on. The radiographs here don't look super concerning. They don't show the full picture, I guess, is a better sort of description. You can again see that head tilt here, but again, it's a little bit hard to tell. Here you can see there's something kind of going on, sort of this cranium in C2. Almost looks like settling or something else, but again, it's a little bit hard to tell exactly what's going on in this case. So the CT, I had a video of the CT. There's just kind of a lot going on. I thought it'd be easier if I just showed exactly all the points. So number one, he developed some basilar invagination. He has this large C2 erosion or mass here, and he also developed a C2 fracture. So he has this chronic fracture there in the odontoid. He has lateral subluxation of the right C1 lateral mass. And then if you look right here where this arrow is pointing, it's just pointing to a space. So there doesn't really seem to be anything there. And so his left C1 mass is lateral mass is completely gone. Now, if you look at these parasagittal images, you can see that yes, that C1, the right C1 lateral mass is subluxated over the right, but you can see it does seem to be relatively in alignment. But then on the left, you can see that left C1 lateral mass is completely gone. He has had some cranial settling right onto C2, which explains that head rotation and that tilt with that he shows in that clinical photo. This CT, 3D CT reconstruction demonstrates a little bit, more about what's going on. And you can tell here that there is something sort of missing. He's collapsed because that whole support right there is gone. Another important thing, he did develop at some point these cranial sort of metastases. And after the immunotherapy, they all a lot of them actually shrunk away, but they left these, defects in the bone, which is also important kind of moving forward. The MRI demonstrates no true subaxial central stenosis. He does have some tenting here on his odontoid, and again, that's in the setting of that basilar invagination. Okay, so lots of things going on with this case. I just try to list out, some of the things here. Left C1 lateral mass destruction. There's no C1 lateral mass on the left side now. Craniocervical rotational subluxation as because of this. Basilar invagination, and then a chronic odontoid fracture. And his symptoms are severe neck pain and sort of this fixed positioning of his neck. I can sort of open it up to the panel here to see if anybody has any thoughts about this case, or if you want me to go back a couple of slides to take a look at it again.
Varun, what's the underlying disease of this man? Is he rheumatoid? Does he have a storage disorder or something like that?
It's metastatic renal cell.
Sorry. Okay, never mind.
Does he
Yeah, I
have
missed
Mets?
that.
Does he have Mets elsewhere, Varun, or is he just isolated here?
Why do you ask that question?
Well, so you can kind of figure out what his longevity is going to be, may influence your choice of reconstruction.
Yeah. Okay. So here, had lots of conversations with the oncologist here. He thinks that because of his response, he has greater than 1 year survival. He did have a recent massive PE. And so, I was kind of going back and forth to the oncologist, the hematologist for a long time about this. And he ended up bouncing back from the PE and everything else, but they still think that he has greater than 1 year survival. And he has a chance to, really fight this thing. He's still pretty young, 50. Though he has this significant osseous metastatic burden, I don't think his visceral burden was that high. So I think that's a great question. So I think with my approach for this case, I think this is tough. He was actually in this position for a couple of months because he was, recovering from this massive PE and everything else. We had a long conversation about whether or not we wanted to do surgery on this, and this was significantly affecting his life. He had significantly increased his oxycodone amount, and we finally got to the point where we decided we're going to do something. And so I ultimately decided on doing halo traction for a week. I didn't want to do it for longer because I didn't want to leave him sort of stationary because I was worried about that PE. And I wanted to kind of maximize the amount that I could correct the deformity, but then also minimize the amount of risks with sort of prolonged traction. And then ultimately doing a posterior surgery on his occiput down to C4, and then also opting for a complex plastic surgery closure, which I tend to do for a lot of these tumor cases, especially in prior radiated areas. So preoperative traction, I think, is a great strategy. I'm a big fan of it. We used it in fellowship a lot. It's really good for deformity, fracture. Gardner-Wells tongs can be used, halos can be used. They can be used, interchangeably. You could use Gardner-Wells for deformity and vice versa. This is actually a picture of him after traction. And so I tend to, if I get to the alignment that I like, and we're going to surgery, then I'll put him in a halo vest. Preoperative traction, I think there's varying protocols for this. I've seen kind of like everything in the literature, just a couple of ones that I've shown here. There's a paper I think out of China that showed with infection kyphosis, they started at 1 kilogram, just kind of increased it gradually. Pediatric thoracolumbar deformity, this is I think one of Dr. Lenke's papers, start at 3 to 5 pounds, increase 2 to 3 pounds a day. And then with cervical fractures, I think everyone's seen this where you start with some amount around 10 pounds and then add pounds based on how low that fracture is. For me, I wanted to start him at 5 pounds. I increased him about 3 pounds a day. My goal was about 30 pounds. He was probably about 200 to 250 pounds. Benefits of pre-op traction, decreased neurologic risk. I think that's been at least talked about. Vascular risk for him, obviously I worry about the vertebral arteries, so I don't want to do a quick stretch on his neck. I think that you can achieve an improved final radiographic alignment, or at least have the potential for that with some a course of preoperative traction. And then I think this is actually really something that I like about it, especially with these occipital cases, assessing their clinical alignment before you kind of flip them over. And like I mentioned before, we got him to a certain clinical alignment. We liked it. I actually checked him with a CT scan before just to make sure I reduced the basilar invagination and everything. And it looked great, and so I wanted to keep that. And so what I actually do, I've done this a couple of times now, is I'll just clamp the Mayfield directly on the halo, and I'll leave them in the vest, at least leave the 2 anterior bars on the vest just to kind of lock it in place, I was actually at a CSRS meeting, and someone had sort of told me about that. I think it was Dr. Brocky had told me about that technique, and I think it works great. Obviously, it's a little bit cumbersome, but I think it works well. We have a Laveau system at Strong Memorial Hospital here at University of Rochester. I think that's a great system. I know Dr. Menga has used it extensively. Dr. Molinari actually told me we have an adapter for it that attaches directly to the halo. So that's another option here. And so these are his postoperative radiographs. So we can see that his head tilt is improved. So these are about 6 weeks. I only did this in a couple months ago. So his head tilt's improved. You can see that just on the lateral, you can see that he doesn't have that sort of cranial settling anymore. We did down to C4 here. And I think, one of the challenges with these cases too is trying to make sure you get the right alignment with these people. If you forward flex them too much, there's always a chance of, significant dysphagia or postoperative airway concerns, which is, a big deal. Obviously, you don't want them, looking up at the sky the entire time either. And that's like kind of part of the sort of concept of this clinical alignment before surgery and just being able to lock in something, because I think it's a little bit easier to tell when you're sort of in that context. One criticism I have about this case, my plate is a little bit more cranially oriented than it probably should. And I was actually using intraoperative navigation for this because I think if you remember, I had that slide that shows that big posterior occipital lesion. And so I was trying to find a place where I could safely put the plate and get as much screw purchase as I can. And so I was doing that under nav to avoid, obviously putting it, way too high that you would actually puncture through and injure something, or, trying to find that balance, especially because the normal anatomic markers were essentially kind of destroyed from the tumor. He's doing well. He actually he's pretty happy with his post-op clinical alignment. You can see he's actually really adjusted his clinical position a lot. And I think, again, the shoulders are pretty key here. Granted, his pain and his neck has obviously decreased significantly. At this point, he has some other, metastatic lesions that he's kind of dealing with too. But overall, we're pretty happy with this case.
This is excellent, Varun. I have a question for you regarding the once you put the halo traction on, you put them in the vest before surgery. If you feel you've achieved your alignment, say if you get an X-ray with the patient in the halo traction and you're taking the patient to surgery today or taking the patient to surgery tomorrow, do you think the vest is always necessary to put them in the vest before flipping them over or doing your surgery?
Yeah, I think that's a great question. Is it necessary? It might not be necessary, but it definitely makes me feel better about, making sure I can kind of get close to what I had. Obviously, there's other checks that you do intraoperatively, but it's something that at least, kind of assuages some of my fears just of kind of losing that alignment that we had worked so hard to get to.
And when you place them prone, how do you get the vest off to begin your surgery?
I just take off you mean the posterior vest? So I think we normally just loosen it. I can't remember exactly what I did, but usually there's a little bit more fumbling around with it. But you usually have to kind of loosen some of the, the buckles and things just to make sure you can get that posterior plate off the back.
And do you tape the shoulders down to create some traction and access for X-rays and all of that?
Yeah, I do. I don't think I went too crazy on this one because, if you end at C4, it's usually not too bad. I mean, the traction, when I really kind of really go on the traction is when I'm getting down to T1, T2. And then even then, a lot of times I rely on APs in addition to lateral for those pedicle screws at 1 and 2.
Yeah.
Another wow case. Hey, Varun, so beautifully done. The alignment, which you've beautifully restored and with nice, safe hardware placement, would be obviously is a nice concern. For me, the overarching concern in a metastatic renal cell C, which I see way too many of, I just had one last week again, is the hypervascularity of the lesion and excessive blood loss during the surgery. This is obviously an area that is not readily embolizable. Did you try or look for an angio beforehand? Did you look at embolization? Did you get a CT angiogram to look at just other vascular anomalies like fetus and vertebral arteries, etc.?
Yeah, no, I think that's great. He did have a CT angio before, and I had one specifically for the vertebral artery anatomy, just because it was going to be so unpredictable or atypical, especially on that left side where that C1 lateral mass was completely gone. I ended up not getting pre-op embolization, which is actually kind of a first for me. I'm actually a very heavy pre-op embolization type of person. The reason why is because all of those masses had shrunk so much. They had almost disappeared. And that's actually why he ended up collapsing and everything. So I figured it wasn't going to be as vascular in that environment. Maybe that was, not as great of an assumption, but it ended up not actually bleeding as much as I was, concerned about. I also pre-operatively had decided that I wasn't going to really mess around with that left side in terms of instrumentation. Obviously, there's no lateral mass to, put a screw into. I'd kind of played with the idea of trying to put some kind of strut in there or something else. But it ended up being something that just didn't make sense for the risk profile. For this guy, my plan was to get his alignment better, kind of get him off, get him into instrument those levels and just kind of get him off the table. Make sure that, we don't kind of set him back too much.
Then to a question regarding fusion, I know this is something that we've talked about and something that we used heavily or did heavily in Rochester with all the cervical fractures, especially C1, 2, when it comes to fusion. And also, I think is good to maybe we should discuss the indications or use of, especially in someone with tumor, of use of something like infuse or use of iliac crest to try to, and this is someone who's also had some destruction of their bone, where you try to establish that fusion surface so they can fuse and not depend on the metal down the road. I think we'd love to get the perspective of the rest of the panel as far as use of iliac crest bone graft or any synthetic products to help or even cadaver products to help improve fusion across that area.
So in our annual oncologic or spine tumor conference, we have a great a collection of people there. And I think there's zero support for infuse or bone morphogenic products. And use of autograft is and remains highly controversial. And I personally have always used allografts and tied them in carefully. Here I would have, to answer Lou Carterara's point, I would have used a structural allograft. We use tricortical iliac crest grafts and an autograft, frozen ones, that we tie into the occiput and cradle onto C2 if that's available, like a clothespin graft, like Henry Bowman taught us in the past. But absolutely no autograft, absolutely no bone morphogenic substances, etc.
Yeah. And how do you so you anchor, you tie it into the rods, and I suppose you have as long as it has a contact with the occiput region, so you have that bony contact and lay some bone more smaller, like demineralized or morselized bone across that.
Yeah, I mean, the main emphasis is to put a structural allograft that's carefully shaped under compression between the occiput and the C2 ring / arch, and cable it down either into the occiput or across the rods. And yeah, morselized allograft can be used as well. In an oncologic patient, the long-term survival is maybe in doubt, especially if supplemental radiation is used. But a nicely tied in and compressed structural allograft is actually quite a nice thing to behold. In smaller patients, Michael Failings taught me that a rib allograft can be quite nice, and it's lower profile than a tricortical iliac crest graft, but you can always shave these down and still be creatively active. So Lou Cortor's question is very good. And the other thing that I've done, but maybe not in this patient, is I've actually put a fibular allograft between the occipital condyle and the C2 lateral mass, and push that in there. And it's also a very gratifying graph to see how that loads, and then actually in models, even in oncologic patients.
And there's also the question of skipping the screw at C1 to, I guess, depending on how you place your screws. I typically take down the C2 nerve root and decorticate the facet joint at 1-2. But with worrying about the fusion from the occiput to the cervical spine, is there a role for not placing the C2 screw in some cases, depending on how the screw is placed, where you maintain all the bony surface over the posterior arch of C1, so you have that surface area to place your graft to help bridge the occiput to the cervical spine? What are your thoughts on that?
I think you just have to be always flexible and see what you have left bone-wise, and always be prepared to do like translaminar screws. And again, we've had patients with literally no C1 and C2, where we just put in the longer allograft and shave it down so that it fits the C3. But the ideal landing site for the occiput is C2, and preserving a good bit of the C2 spinous process is beautiful, because you don't need C1 or anything like that. The structural allograft is properly wedged in, and carpeted in with a press fit and cable down. Feels quite nicely, I must say.
Okay.
And Jens, why the thumbs down on the autograft? You're worried about tumor being there or handicapping the patient? Because classic Henry Bowman occipitocervical fusion was outer table, corticocancellous, structural, and biologic, obviously, on the intertable graft.
So we had a couple of really cool people at our last tumor symposium, like Zia Gokazlan, Mike Bilski, Dan Schuba, and the general consensus is not to use autograft, certainly not local autograft. If you wanted to use for whatever biologic reasons, with long-term survival being the goal, you'd have to pre-screen the pelvis and make sure that there's no lesion in there. And for these tumor patients, adding another pain surface and wound to their already significant disease burden is just seems inordinately difficult. Yeah. So one wound is enough to heal and invest their protein in, rather than giving them more healing surfaces to deal with. Anil asks occipital condyle screws. So I don't do those. If you have navigation, I know that some of the Germans have postulated them for a long time. I just think that if you have central keel screws, and with the modern plates now, you have a wide variety of implant options depending upon where the occipital lesions were. Varun did a great job planning for that. You get navigation also to avoid skull lesions. But I've just never seen a need for C1 screws. And some of our Swiss surgeons have done like magical C1 to occipital screws, but it's just not necessary. Modern rods are so well contoured and strong as long as you don't do a malalignment. And this is again a beautiful case of realignment of the neck that Varun showed. So I don't see a clinical need for occipital screws, although it's now again more possible to do it with the power of navigation. Varun, any thoughts?
No, I agree with you completely, and I mean I felt that way as well. I think that I was able to get good purchase, and just by using navigation, just like you said, you're able to kind of make sure that you get good screw purchase on each of those screws that you get. So you're like kind of aiming right into the area where you can get the best bony purchase, and so I think that was helpful in this case.
Varun, how far out is he now, and how's he doing?
He's about 2 months out now. And obviously I don't have long-term follow-up on it. From the neck standpoint, he's doing actually really well. He's actually maintained his alignment. He's not, complaining about his narcotic burden actually decreased. The problem is now he's got some osseous mets at other places that are kind of playing a role now. And so that's kind of the natural course of the disease. At the end of the day, it's always tricky to figure out if what time is the right time, I think, to, operate on these patients. And I think just having a, pretty close discussion with them, making sure you kind of establish that relationship is really helpful for that.
You did a beautiful
Yeah.
job, and I like your preoperative traction and operating. Sometimes in trauma, we would do the same thing, lay them down in their halo vest, and then take the posterior vest off, posterior portion off, and operate that way. But it just saves a lot of fiddling and instability maneuvers intraoperatively once you have them in the position that you like and they're neurologically unharmed. It's a
Yeah.
great job.
No, I agree. Thank you. I appreciate that.
Yeah, great job, Varun.
Yeah, that's excellent. All right, we'll just jump into the next patient, and hopefully with enough time to get to the last patient from Varun. So this is a 65-year-old male. This is actually a patient of one of my neurosurgery colleagues here in Miami, and he invited me to take part in the surgery. Unfortunately, he's unable to join us today to present the case. Patient presented with neck pain and upper extremity pain, head tilt with difficulty walking, progressive head tilt with in the coronal and sagittal planes, severe pain over the left trapezius, radiating pain throughout the left upper extremity and no specific dermatomal distribution, clumsiness in his hands, dropping of objects, difficulty with using his fingers, gait instability. So some typical findings you see with radiculopathy and myelopathy, at least on his history. History of Chiari syndrome with Chiari decompression several years before, syringomyelia, and a previous C3 for ACDF, hypertension, depression. So on exam, and I have a clinical picture to show you. He has a stoop posture. I need to share this again. On exam, stoop posture with rigid chin chest deformity. I had him lay down on the table to see how much excursion I can get with his chin, and it was pretty tight. Right-sided head tilt, right trapezius contracture, had normal strength in the upper and lower extremity. No long track findings on physical exam besides the gait instability, which may be just because of his clinical posture and years clinical images. So you see with the far left image, he's standing with the head tilted forward and to the right side, and you see the side images sitting down and standing up. Those are the clinical pictures, and it's quite rigid. This is AP lateral flexion and extension views with no significant changes in his posture. Maybe slight improvement with the as you see with the extension film, but mostly quite close to his neutral position. So recommended we get a full scoliosis X-rays. As we know, we see some patients who present like this, but it turns out sometimes it's mostly a lumbar deformity and not so much a cervical deformity. I think I have an example of a patient that will present with Dr. Molinari at our next session. So this ends up being mostly a localized cervical and maybe upper thoracic, but mostly cervical deformity. Had the previous lumbar surgeries there. This is the MRI, and the image to the left side is a scalp CT scan. So I tend to use that sometimes as my, I describe it as my lazy man's flexible or prone or supine image. And you see on that CT scan on the left side as a scalp CT with a bolster in the back of his cervical thoracic junction. You see there's no significant improvement in his posture. And then the MRI, which I think of the MRI more as, I mean, some of these patients, you lay them down when you get supine x-rays, they're guarding against pain, so they still do not relax, and you get the x-ray in 15 minutes, and they're still guarding. With the MRI, I tend to think of it as the patient is laying there for about 30 minutes, depending on the MRI machine, and at some point, their muscles give up, and maybe they relax a little bit. So I even use that for my adult scoliosis patients, where I look at their coronal MRI to get some idea as to how flexible the deformity is, rather than relying on just a supine image with bolsters sometimes, because even I find that that's painful for patients sometimes. So the MRI, I use that because they're laying there for a while and the muscles ultimately give up with the guarding. Yes, a CT scan with a rigid deformity. He had a previous fusion at 3-4 showing fusion. And you can see the patient has also had some autofusion at 4-5 and 5-6. And that's the axial showing part of his previous decompression posteriorly. And this image is meant to show the syrinx. You see the syrinx, and then we'll scroll through the sagittal, through the axial MRI, and you see the areas. So these are the key areas of severe stenosis at 3-4, 4-5. And this image is really mostly meant to show the syrinx throughout, extending from the cervical spine into the thoracic spine. For the sake of time, as far as what next with surgical intervention, do you go anteriorly? Do you go posteriorly? Is it even possible to get in anteriorly? As I mentioned, I had him lay down on the table in the in clinic to see, and just had him lay down and see how much I can push in his neck. And then it wasn't that flexible, but I felt maybe with some anesthesia, we may be able to get some. And the plan was to lay him supine on the anesthesia, see how much more excursion we can get to potentially do an anterior surgery, because the whole goal is potentially avoid a 3-column osteotomy in the cervical thoracic spine, which you know can be high risk with the vertebral arteries. So in his case, again, for the sake of time, we opted to try the anterior approach, and if we felt we could not get in, then flip and do it all posterior. Put him in a halter traction for all my ACDFs. I don't use pin traction. I typically use also the halter traction. I think it allows me to extend the chin and put some weight on it. And with that, we're able to actually extend them up and get access. And I think this is one of those interesting cases. I think the access was alternating back and forth between myself and my neurosurgery colleague. You know, he started, the exposure went down. It got to a point, I'm retracting for him. You know, the resident is standing right there, and it's like, oh, he's getting pretty tight. Let's see. Let me take a look. So we switch sides, and I go in and I play around, and I get to a point. It's like it's really tight, and he thinks, oh, let me try this, and it will come back. So we did the musical chair and we finally got down to the spine between the two of us. And then we did a partial corpectomy and put in those standalone devices. The goal was to place screws only at one level to still allow some flexibility when we flipped the patient over to allow extension. So we didn't want to lock him anteriorly, so it gave us at least some room posteriorly. And then did posterior column osteotomies at these C5, 6, and C6, 7 levels. And we're able to, and then did the revise his previous decompression, and we're able to extend him to this posture. Yeah. Yeah. Any thoughts on different approach? Your thoughts on 3-column osteotomies in the cervical spine?
Congratulations. You're an amazing surgeon. This is as hard as it gets and so unforgiving, especially a Chiari patient. General thoughts before you go to your last case. I like to see a timeline and look through the old images as much as I can to understand where and what's decompensated. Yeah. I usually give a lot of these patients a feeding tube due to the high risk of dysphagia. And I start that a month before because I don't like to fight about swallowing in these patients. And you did a lot of things so nicely. For a rigid kyphosis, which I agree, you have to kind of do a recumbent test with them, meaning a laying down test to see how far they distract, whether their SCMs are contracted, etc. I usually do front back front, so I'd do 1 or 2 or 3 level discectomy / corpectomies until I have a left through right, meaning left uncovertebral through right uncovertebral, full anterior release, and then do a posterior surgery. Then painfully go back in the front again and do structural allografts there. Very painful surgery without a question, very lengthy, high risk. In him also pretty small cord substance. This looks like a 3 millimeter cord or so around that syringe. So super high risk in all regards. So kudos to you. He had no swallowing difficulties, no C5 palsy.
No, he did great. It's being surprised about it. And with the traction posteriorly, it's one of those with a halter traction, was able to pull the weight to one. So he was tilted to the right side and we're able to pull in trying to, because we didn't want to put that cage in to unlock him in the same posture. So we're able to pull the traction in one direction to try to even out as we're doing that exposure. And luckily it worked out well.
So you
Had some,
got it
had some
anterior
neuromonitoring
posterior only.
changes. Yeah, we did anterior posterior. Yeah, had some neuromonitoring changes, but not significant. I think it was like a unilateral decrease in MEPs. SSDPs was intact, and everything recovered while we're still operating. So, but that was the biggest scare during the surgery.
That's amazing.
Manny, when you did get the changes of the MEPs, did you just stop and wait a little bit, or did you just keep on going?
We bumped at that point. We felt nothing had really changed that significantly, and the intensity of the decrease. I think it was like a 25% drop in the MEPs.
Okay.
SSCPs was still fully intact, so we just bumped up his pressure, gave him some steroids, and continued on.
That's a
Terrific result.
great case.
Amazing.
And the concept anterior releases and then gain something posteriorly. And whether you do it in 2-stage like you did or the 3-stage, as Jens was talking about, I think the concept is brilliant. That's what you need to do in a stiff deformity like this. So great job.
Thank you. We'll see if we can jump into your last case, Varun.
Yeah, no, I mean, thanks for sharing that case. That was a great case. Too bad I have to follow that now with this one, but let's see. All right. Can you see my screen here?
Yep.
Yep.
All right. Second patient. All right. 35-year-old woman, C57 discitis epidural abscess that was diagnosed at an outside hospital 5 months ago. She was treated with a halo vest and antibiotics at that time. She developed progressive deformity of her neck, worsening upper and lower extremity numbness, difficulty with eating. She said that she was kind of walking like a baby. Those are her words. And she had a diffusely myelopathic exam. She was very hyperreflexive. This is what her radiograph looked like when she came in to see me. So again, this is 5 months after being originally diagnosed with the cervical osteomyelitis disguised in abscess. Let's keep going. This is a clinical photo. It's kind of hard to see, but this is actually a chair right here. And I was trying to show that her chin was on her chest. Obviously, this isn't the same kind of rigid deformity that Dr. Menga had, but these are the lateral and AP radiographs. Here, we can see the CT scan. So C2, C3, C4 is partially eroded. C5 is almost completely gone. C6 is, I would say, almost completely gone. C7 is partially eroded. You can see that a little bit of that here on that coronal CT cut as well. Now this MRI is, I think pretty striking, right? There's dorsal epidural abscess here, but that's not even, close to kind of what the important stuff is. Here you can see that there's abscess and phlegmon that's kind of surrounding all these bone parts, pieces. The spinal cord is completely compressed. It's tented over this large, ventral area. She also has this large kind of phlegmon abscess in that prevertebral space, which I think is also very challenging to manage just from like a surgical perspective as well, especially with exposure. All right, let's just to kind of keep moving here. So diagnosis, near complete destruction of C5 and C6, partial destruction of C4 and C7. She has a epidural abscesses. She has a prevertebral abscess. She's clearly myelopathic, and she has this sort of chin on chest type deformity. Not the same type as Dr. Menga's, but she does rest with her chin on her chest. So plan here. And I think, we'll just kind of keep going. But, one thing to note, right, just like how Dr. Menga said, if you're supine in some of these, cross-sectional imaging studies, this with a CT scan, you can see it is kind of partially flexible, right? It doesn't look as bad as the radiograph, so we can actually, kind of extend her through that. And, I guess, for this, I thought the same thing. I actually wanted to do traction on this, preoperative traction with very close monitoring to make sure her signals didn't change, her myelopathic, she didn't start developing weakness or anything else. So it was kind of traction in the ICU setting, kind of watching her like a hawk, making sure there's an art line in, so on and so forth.
Varun, was she toxic, or were these old chronic inflammatory changes from treated epidural abscess?
Yeah, so toxic, I think you mean by like inflammatory markers and like sort of systemically.
Septic markers, yeah.
So she actually wasn't well, she was septic, but she wasn't toxic appearing. So she didn't look like she was like on the verge of kind of crumping or anything like that. These patients tend to be they tend to be pretty resilient, I think is probably the best word for it. But so she like luckily wasn't in that case.
But no septicemia. I mean, she didn't, positive cultures where you had a rush to do this.
Yeah, she had positive blood cultures, but I didn't feel the need to kind of rush into a surgery just because she was on the verge of kind of crumping. Okay, so preoperative traction for her. After traction, this is just a couple of days of traction. We straightened her out to sort of this orientation. This is what her clinical alignment looked like. And now you can see her chin is clearly off her chest, and you can actually access her anteriorly and access her neck anteriorly. And she has a big smile on her face here too. All right, so after pre-op traction, I went ahead and did a front-back cervical corpectomy with posterior cervical decompression fusion, kind of similar to what Dr. Menga did, but obviously different indications. For this, I did have Dr. Wong, one of our ENT colleagues, help me with this case. For me, I feel more comfortable with him there for exposures for these cases, just because of that huge prevertebral phlegmon, which sometimes can, especially if it's been there for a while, can erode into some of the soft tissue structures of the anterior neck. And so these are her post-op radiographs here. So pre-op versus post-op on the right. We took C4, C5, C6, and I took a little bit of C7. So I ended up docking that cage right in there. And this is a CT scan just showing the extent of that resection with the laminectomies in the back and probably a cross-link right here.
What biologic did you use?
I did end up using BMP in the back. And so I remember, I think I actually talked to Dr. Menga about this case, I think a year ago. And we had talked about it just because I think there's I was worried about her chances of fusing. And I think using bone morphogenic protein in this case, obviously it's off label, right? I have to, be pretty clear about that. But, I think it's something that people use for this because it doesn't have the same, risks that you would do with that tumor case that I showed at the beginning.
What do you use in the front?
I just used allograft in that titanium cage. So I didn't use anything crazy. I've never used bone morphogenic protein in the front of the neck. I'm not saying that's necessarily wrong because I know people do it, but I do get a little concerned about the anterior risks.
Well, I mean, certainly there's a difference between, and I mean, in terms of Wolff's law, between a compressive fusion and a tensile fusion. So obviously the high risk is the tensile fusion in the back, and BMP makes sense.
Yeah, and there's good evidence to support for some of these patients with infection that BMP actually helps improve the odds of fusion. But anteriorly, I agree with Varun. I know of people who used it, but I've never used it myself. I think the question I had for the panel and also for Varun is, one thing I learned from Tom Errico during fellowship, this is more for A-lifts. I know Kabesh used a similar technique at Hopkins, but would use, and that's what I do when I do cervical corpectomies. I still use a mesh cage, but I use like a fibula strut that I jam into it. And so I'm not relying on that possible like secondary bone healing that can lead to erosion. And we know that erosion sometimes never comes back to the reabsorption phase, never goes to fusion. So I put a strut into the mesh cage to create that rough edges at the end. So that way I'm just depending on the fusion above and below and not worry about anything below in between. So I don't know what your thoughts are about doing that versus doing either just an isolated fibula strut or using a morselized bone graft like this.
Well, the faculty all grew up with isolated fibular struts and a plate, and we had certainly a specific incidence of failure. But with these mesh cages and some type of whatever bone graft or bone graft substitute you like under compression, it certainly works a lot better than what we had 30 years ago.
And plus adding the posterior fusion.
Oh yeah, posterior fusion, posterior fixation, particularly the way you can navigate screws into pedicles now. I mean, it's a game changer. I mean, more stability, the better on these cervical fusions.
Varun, when you got in both the front and the back, was it just phlegmon or did you actually see gross pus?
Sorry. Yeah, it was mostly phlegmon. There's a little bit of that sort of liquid pus there, but it was mostly that phlegmon. The anterior neck was very scarred down, and it was like, using retractors and like pulling it. And I was so thankful that ENT surgeon had helped me with
Yeah, amen to the ENT surgeons.
yeah.
Yeah, this Varun, you deserve so much credit for taking this patient on, and this is a beautiful case. She's so lucky to have found you. I The ENT surgeon, we had a severe esophageal injury from a colleague of mine who was barging in on one of those contracted anterior necks by himself, and a bad esophageal injury occurred. And I congratulate you on having the foresight to have an ENT colleague and trying to get us straightened out as much as possible. So that's very cool. The BMP reference for osteomyelitis, by the way, is from Steve Garfin, Alan Steve Garfin. He published the Sentinel study for this, and I completely agree with Emmanuel. This is a key thing to kind of incite bone healing in these patients, and not anteriorly, this posteriorly.
Well, the nice thing is when you have an ENT colleague and you're doing a complicated case and there is an inadvertent injury, you can step back and say, "Sir, you have a problem."
Yeah, Varun, I think we've talked about this. I think, most anterior cervical cases revision, I tend to do most of them myself, but I'll tell you, each time I've used ENT, I've always been happy about the fact that I used them. And even this case that I did with, so Shelby Burks is my neurosurgeon colleague I did the other case with. In retrospect, it was like, maybe we should have got ENT to do that exposure rather than having the two of us going back and forth to get the exposure down. But I've never regretted using ENT for a revision anterior cervical case or complex case.
Yeah. Manny and Varun, as we've gotten older, our threshold for inviting ENT to participate has gotten lower and lower. So it's good to make friends early.
Yeah.
Yeah,
those
totally
are
agree.
These are four great cases with great discussion. You guys did a great job presenting these and leading the discussion. So it's a great educational hour. Jens, anything to say before you take off?
Anterior and posterior column, and a thoughtful approach in every case with a lot of attention to the detail and circumspect management throughout. Hats off to you guys. Thank you for lively discussions and certainly very challenging cases. Very well done. Thank you.
And excellent results.
Thank
You guys rock.
Outstanding. Thanks for being part of the family.
Oh, thank you.
Everybody stay
All right.
safe. We'll see you again soon.
Take
Great
care.
night. Thanks.
All right.
you.
Good night,
Thank
everybody.
you. Thank you. Bye-bye.